You'll be very pleased to hear that my presentation will be just like me, very, very short and sweet. And I also want to finish quicker so we can have some more ouzo, because I tried it last night and it was absolutely amazing. I'm a community pharmacist. I don't have any water around my pharmacy. I've been there 11 years, but we are surrounded by sharks. There's a lot of multiples, and I'm the only independent within the area. And being a contractor for 11 years, I have obviously got a good idea of how to run a pharmacy. But also, I was on the money negotiating committee, which we call the PSNC, and I'm also on the Royal Pharmaceutical Society. So I have a professional side as well as a contractual side as well as a negotiating side. So one of the things that I'm going to be talking about will be around why we needed a formula for discussion for negotiation. Previous negotiations were settled really on crude statistics that didn't take into account lots of variables. Pharmacy in the UK is very complicated. It's extremely complex. The independents like myself are in a minority now. Most of them are multiples. But within the multiples, they have small pharmacies and large pharmacies. Some independents are large, and some are even larger than some of the individual stores of a multiple. Also, our funding structure is quite complicated, because while we have a global sum of professional fees and allowances to dispense, we also have additional money outside that to do other services like flu vaccinations, prescribing, smoking cessation services. And so any negotiation has to be just purely around the bread and butter of dispensing, because the safe and efficient systems are a priority. So it's about negotiating for more money, but it's also about efficiency, and that's what's key in all of this. So, just as a background, we had a new contract that started in 2005, and before that we were getting 600 million a year for all the 10,500 pharmacies, and after negotiations it went up to 1.76 billion, and now it's 2.8 billion. And I'll be touching base on why that was increased and how. The methodology of the cost of service inquiry is extremely important, because we wanted to develop a formula, a methodology, that you would put a load of numbers, that variances like inflation, geographical variation, costs of regulation, training staff, and we wanted to make sure that every year we had something we can go to the government with and negotiate with based on the statistics that they themselves would be privy to. So one of the things was the government demanded radical change. They wanted to see improved services, consistency, and increased access. So that's one of the reasons why the contract was negotiated. They said, it's understandable that information management and information technology is not a luxury. It is now a very valuable tool to help us deliver an ever-increasing workload in terms of collecting evidence, audits. Computers, even when I graduated in '94, were just very glorified labelling machines. We are now using them to monitor patients' outcomes and recording their statistics in there. So that's quite important. We can help cut waste. In the UK, we have so much research now which shows that a third to a half of all patients don't take their medicines as they're meant to, which means that apparently about just under 7% go into hospital because they're not taking their medicines properly. This is something we can be involved in. There's roughly around 300 to 400 million pounds worth of medicines wasted in the UK. So when the government says we have no money, potentially we've been saying to them, we can help you save that money, but if we do, give us some of it back. So for every £1 you invest in community pharmacy, we could save you £3 to £10. So that's quite important. The other thing is, anything that they delegate to us, we have to make sure that there's no compromise in quality, that it's at least going to be the same, if not better, that improving access means patients have quicker access to care, which means that their treatment is less complicated, and that they'll get better a lot quicker, which means a quality of life. More importantly, proving value for money. So out of that wasted 300 million, it's been proven that we can save the government at least 150 million of it. On top of that, all the people that go to see a GP, we can save the government 2 billion a year, because those patients could be treated in a pharmacy. This is all research stats that have been shown in the UK. So whilst it's always about the bread and butter, it's also about proving how invaluable we are. I mean, Superman wears his underpants on the outside of his trousers. We've not got there yet in pharmacy in the UK, but we're nearly there. So as a funding within pharmacy, you've probably seen this picture a million times already. So we have the self-care, which is the OTC side of things. We have the services, which is outside of the allowances and fees. So, like I said, medicines use reviews, vaccinations, new medicine services, smoke cessation, weight management, emergency hormone contraception, substance misuse service, so on. But the real thing we're going to be focused on is the remuneration, the basic line. And that's what's so important, because you cannot involve the other two in negotiating the important baseline for pharmacy. So, out of that remuneration of 2.8 billion, 2 billion is for the allowances and dispensing, 800 million is to keep the market competitive to drive down the cost of generics. Because if everybody earned the same amount of money, then the generics would creep up. By introducing competition to the market, the generic prices go down. So they give us some money towards that, driving that competition. So all pharmacies in the UK, to get a slice of the global sum, the basic remuneration of dispensing, have to fulfill everything in white on the chart. This allows consistency, it allows clinical governance and patient safety. The yellow is if you wanted to do extra services outside of the global sum, with a little bit of training, you can do those. And if you're extra ambitious, then you do the enhanced services. The enhanced services could be any of those there, and again, this is not part of the global sum. Now, this is important because it will impact on the global sum, and we have to take note of them. So these are all services we could be offering in the UK if it's commissioned, but it's variable because some areas will see it as a need and will pay for it extra, some don't see it as a need and won't pay for it as extra. I myself do vaccination, I do weight management, I prescribe travel medicines and inject them. I won an award for Britain's Best Pharmacist last year. And I take blood to check for hepatitis B and C. But that's just a small selection. And my staff equally get involved in a lot of the stuff that we do. So, I had to give you that quick background because this is now where the importance lies. So, we've got about 10,200 pharmacies back in 2009 when we looked at this. And we wanted to develop a formula that moved with the times. We wanted a formula that, although as the times changed, the formula itself would take into account those changes. The government agreed to pay for this review. And although the government paid for this review, we worked quite closely with them, along with analytical, statistical, financial, economical experts and professors. Everybody but Jens, basically. But everybody was involved, but it was a totally independent survey, and it was approved by the government, and PricewaterhouseCoopers conducted it. So you couldn't say there was any pharmacy bias in it. They said we need a minimum of 500 samples, and we looked at how we would stratify them. Now, you would look at the size of the ownership of the pharmacy, whether it's a multiple, a large number of independents, or just independents. Independents being less than 5, larger independents being more than 5, and multiples being 30 or more pharmacies. Then we looked at the amount of dispensing. So those are 20% or less of the dispensing percentile were in one sector. Then it was 20 to 60%, and then above 60%. And then it was other services, because we didn't want to include the other services because this had to be about the dispensing. So potentially you had each pharmacy could have been in one of 27 layers. And we had to make sure that location was important, because obviously costs will increase with that. So PricewaterhouseCoopers rang up, so nearly 1,500 questionnaires went out. We had 40% back, which was nearly 600, so that was quite safe. We made sure that the figures used were submitted accounts, so nobody made up any figures. We made sure that the cost and revenues were incorporated, because you had to take into account whether it was NHS or non-NHS. And we had to include that it was site information. Now this was really important, because you could have small multiple stores, but or you could have large independents, and they had to be taken into account about their overheads. So the cost of service inquiry, very simply put, is operating cost versus the fair rate on investment. That was the basic formula. Now there was honestly hundreds of formulae used, and we're not going to have time to go through each one of them. So the formula would have included, for example, the owner costs, the head office costs, site costs, staff costs also being people like delivery drivers, the training of staff, as well as the usual pharmacists and dispensers, the cost of regulation, the property costs, depreciation, for example, fixtures and fittings, replacements, others, for example, subscribing to a professional body, marketing, advertising, staff uniforms, all of those were included. And then they were divided into what would be costing the government, because it's a service to the government, what would not be to the government, i.e., putting things on shelves and over-the-counter medicines, really the government don't want to pay for that, fair enough. And then the common costs, like having consultation, which might be used for private purposes or might not be used for private purposes, but would be used for NHS and non-NHS. So had to take into account all of those. And there's formula for everything. All done independently, all done in accordance to competition authorities and regulators, all done according to stock exchange and treasury indices. So none of this has been done by somebody sat in a pub, taking a pen and writing on the back of an envelope. This is all done through tried and tested formulary. And then and we had to include certain things like the long-running incremental costs, which would be the costs that could be avoided if a pharmacy shut down. And fully allocated costs of having a percentage of what was NHS and patient dispensing related and what was not. So everything was divided into, is that NHS and what isn't. You had to take into account all of those things, because sometimes if you just take into account one thing, you're missing the bigger picture. So we had to make sure that we looked at lots of things. So this inquiry took over 3 years to make. And it was interesting, after the results came out, the government actually invested more money in us. So WACC is the weighted average of capital cost, because one of the things that you need to look at is the cost of debt versus the cost of equity. And then you have to look at your tangible and intangible assets and consider how much you deserve to come back on that. What was extremely important is that obviously operating costs can vary, but defining the fair rate of return was a bit more difficult, because the fair rate of return, you might presume, you want to be rich, could be quite high. On the other hand, the government might say, no, the fair rate of return should be quite low because we can't afford it. So how we define the fair rate of return is the amount of return you'd expect on an investment in a competitive business to keep making it more invest-worthy. So based on that definition, we did all the stats, we churned it all into these different formulae, and it's actually independence proved to be cheaper to the taxpayer than the multiples, which was quite a shock, because you'd think big is better. You'd think the larger, the more efficient they are. You think that because they're bigger, they're cheaper. It actually works out differently. They have higher overheads, head office, higher turnover of staff, more training costs with those staff, and also, funnily enough, employees don't tend to be as happy either. So by training more and more people coming in and people leaving, it actually adds the cost, which then goes into services. Unfortunately, when they do the average, it pushes our costs up because they have to include everything. So in fact, multiples cost the government more money than independence, which is the first time, which surprised us and shocked us all. The non-retail DM means driven market. So you could have a massive pharmacy with a massive store with a small dispensary in it, where most of it is non-NHS, and that's a retail-driven multiple. Then you have the non-retail driven, where it could be a small multiple with a massive dispensary in a shop and a small shop. The good thing about this cost of service is it took each site on its own. So the costs were done for individual sites, not what head office said the site would cost. So therefore, it was pretty accurate. So what we have to realize is, and I'm about to finish now, so what we have to realize is this. The principles are that the figures that have come out aren't exactly accurate, because you can never be 100%, but you could be as close as damn it. What it does definitely tell you, though, is a costed data and a range of conclusions, which could potentially be interpreted in a variety of ways. However, it is the start of the negotiation. You start up there, not down there. And that's extremely important. So when they're turning around and talking to you about, what the fair rate of return would be in that equation, you go back to that old thing that I showed you earlier on: increased access, improvement of care, reducing waste, supporting the healthcare network being cheaper. And I think then what happens is then the negotiations will be nearer your end of the market than what they would like to see. So it adds as a benchmark, and more importantly, it retains the purchase profits, which is so important. And I'll just leave you with that. Efraristo, and thank you very much for inviting us. Thank you.